Okay, the final chapter in Unit 4 is Chapter 13, which is the transfer of learning. So we're going to talk about kind of diving in more into like transfer testing and how learning gets transferred to performance. So again, kind of going back to some of those Chapter 11 and 12 concepts. So transfer of learning is one of the most universally applied principles of learning in education, sports, dance, and rehabilitation. Now, obviously, as you guys know, with me being a physio, we're going to talk about some rehab specific stuff, and you'll kind of see how it applies in this context to things that happen in rehab and things that I see frequently in the clinic or things that happen in more rehab spaces like in a hospital. So first of all, let's talk about what transfer of learning is. And transfer of learning is basically the idea that as you learn something, it gets transferred to your performance. Simple as that. So you're able to apply it into a new context, or you're able to take another skill and apply it to a new skill. So this can happen in two different ways. So I guess three is positively, negatively, or neutral. So that implication of that old skill or your ability to transfer your old knowledge to a new skill could happen in a positive context, which is called positive transfer. And it can also happen in a negative context, which we call negative transfer, where your previous learning is actually harmful to your new learning. And then obviously there's also zero transfer, which is just a net neutral. It doesn't make you better or worse. It's basically just no influence on your learning. So why is transfer of learning so important? So when we talk about kind of developing new skills or being able to kind of learn process by process, this is when we're going to tap back into Chapter 1 stuff, which is Gentile's four-dimensional or two-dimensional taxonomy. Sorry. When he talks about that taxonomy, it presents with 16 categories. As you guys know, it starts at 1A, it goes all the way down to 4D, from less complex to more complex skills according to those categories. She organized the sequence of activities by listing the first activities that a person must perform before performing more complex or difficult ones. So this is kind of what we do in rehab, is we say, hey, what are you good at? What can you actually sustainably do? What level are you at when you actually break or you can't do that skill anymore? And then that kind of helps us hone in on where to rehab you. But you could also do that for like skills like throwing a ball or swinging a baseball bat or making a basketball shot. Like those are different components that allow you to pick a step-by-step process and put someone in a position where they're most likely to succeed so that they can actually transfer their learning positively going forward. So that's how Gentile's two-dimensional taxonomy can be applied to motor learning and transfer of learning as well. So then next we have to ask the question, why does positive transfer of learning occur? And this graphic right here is figure 13.1. It actually does a great job of explaining why this happens. Is when two skills are more similar, when they share more components, it's going to be easier for you to transfer that skill versus something that is dissimilar. So those are little things that you're going to take into consideration. So we use that example in the last chapter of, you know, what does a baseball swing look like compared to a golf swing? Well, at its core, relatively simple, right? There's some good crossover there, but there are certain components of a golf swing that are not the same as a baseball swing, right? Or we might look at two different skills. We might say, well, you know, swinging a baseball bat and kicking a ball, not super similar. There are components that are the same, like weight transfer, right? Or you know, body weight transfer or stuff like that that may look similar, but the core of the skill itself are very dissimilar. So that's how you get positive learning, is making sure that there's a similarity of the skill and context components. So again, we want things to look relatively similar, and that's going to help you be able to transfer that skill over, or help your athlete or your student transfer those skills over to a new skill. Next is when we're looking at these similarities of skill components, we would expect the amount of transfer between a tennis serve and a volleyball serve to be greater than between a tennis serve and the racquetball serve. And for comparison on the basis of similar context components, we would expect a higher degree of transfer to occur when practice conditions include transfer test context characteristics than when they do not. In a clinical situation, for example, physical therapy protocols that would include walking in a patient's everyday living environment will yield more positive transfer than those only in a clinic. So let's go through these two components here. You have to have a similarity of skill components. So the amount of transfer between a tennis serve and the volleyball serve would be greater than between a tennis serve and a racquetball serve. So why is that, right? So when we think about tennis serve and racquetball serve, well, racquetball is a lot more wrist action than tennis. Tennis is pretty straight with your hand and with your wrist, kind of like volleyball, right? Like volleyball is like your hand stays and your wrist stays pretty stationary. There's not a lot of flicking of the hand or flicking of the wrist. You're keeping your arm pretty stable, just as you are with the tennis racket. And so we would expect tennis and volleyball to have a little bit more similarity, even though you're not using a racket in volleyball. However, in racquetball, there's a lot of wrist motion. There's a lot of snapping of your wrist and snapping of the hand. That is something that you don't do a ton of in tennis. It's not to say there's not transfer there. It's just not as similar as volleyball compared to tennis versus racquetball compared to tennis. The second component is these context components, right? So we're going to see better transfer when we practice in environments that are going to look like the real thing, right? So that's when we talk about physiotherapy, when you walk in the patient's everyday living environment. So when you bring them into their home, or if you put them into situations that they frequently are involved in. So if you take them to the mall, if they like to go to the mall, how does that transfer over? And that's where we're starting to see in the rehab space a little bit, is we want to see transfer to the environment. And that's a little bit of the weakness. So what I do is I work in a clinical setting, which is great. Patients come to you, but then you're trying to reproduce that environment in a different context than what they would typically see in their everyday. So they basically talk about here, it's just like there's merit in both hypotheses here. There's merit in starting with that Gentile's two-dimensional taxonomy and progressively working through that, and you can use those skills to do that. There's merit in, using the similarity of skill components or similarity of context components. It really doesn't matter. It's just about making sure that when you are giving people those things, they're at an appropriate difficulty, and that you can expect the amount of positive transfer to be related to the amount of similarity between skills and performance context. So whether you change one or the other or both, as long as you're trying to make it as similar as possible to that environment, you're probably going to get a positive transfer. Now next we're going to talk about negative transfer. And so negative transfer, again, the implication that the instruction or the skill that you've previously learned negatively transfers to a new skill. So we're going to talk about rehab and negative transfer. So when physiotherapists interact with patients who have learned to perform a skill in a certain way because of a disability. So you may see people who have had even as simple as an ankle sprain, all the way up to things like amputation or a stroke or a traumatic brain injury. If you have seen people at some point in their lives where they've had a sore ankle or a sore hip or a sore knee for so long, they have a degree of disability, they're going to actually negatively transfer their old walking pattern to a point where the walking looks terrible, right? They've relearned the skill in a way that is not efficient, it's not smooth, it's not economical, and so now it starts to look poor, at least from our perspective. It's still effective, it's still getting them from point A to point B, it's just not as efficient or as nice as we would want it to be relative to their skill level. So if we take a stroke survivor who is post-stroke several months and they're walking with a gait pattern that distributes force asymmetrically with more force directed to the unaffected leg, this leads to less time spent on the affected leg, and so it looks very hitched and it looks very limpy, so to speak. However, the therapist knows that continued performance in this manner will lead to additional physical problems, which means the patient must acquire a different manner of walking that he or she has been using for several months. By using these types of situations, people typically show a decrement in performance when they begin practicing a skill in a new way. But with continued practice, performance begins to improve and a new way of moving is produced. So these are kind of things that, we need to break down that skill. We need to it needs to look crappy. It needs to look terrible initially in order for them to relearn how to do it a proper way. So negative transfer effects are temporary, and this is because negative transfer effects in nature typically influence the skill learning in only the early stage of learning. So when you're trying to learn something new, when you're trying to apply a new way of thinking or a new way of moving to a skill, there's going to be some negative transfer, right? There's going to be some negative effect to the way that you perform, but the overarching idea is to take that negative transfer and spin it around and eventually turn it into a positive transfer. So why do these effects occur? Well, the first relates to memory representation developed as a result of learning a skill. So if there's a particular memory in the brain of a skill, it is initially challenging to transfer that skill's memory into a new context. Right? If you're learning how to do something very specifically, like drive a car and shift with the right hand, you've already made that context pretty solid in your brain. So then when you go to the UK and you're saying, hey, now I got to shift with my left hand and then signal with my right, it's going to feel very awkward because you've been used to doing something in a very particular way. So this is where you can get negative transfer. Another possibility is that negative transfer results from cognitive confusion. So again, when you drive this car and the shifter's on the left-hand side and the signaling's on the right and it's all backwards and the lanes are backwards, it causes some confusion because you are used to a particular pattern or a particular way of doing something, and so that can change the way that you perceive that action. So the keyboard example here is a great example of cognitive confusion. So you've had a similar experience when you change keyboards, when you get a new computer. You're used to keys being in particular locations, like your backspace or your enter or your delete. So when you first begin typing on the new keyboard, you have difficulty striking the keys that are in different locations. So you get some negative transfer because you knew about your old keyboard, right? That is something that you tried to transfer over. Now you try to use this new keyboard. It doesn't work because you're not used to where these keys are. But over time, again, because negative transfer can be temporary, you end up relearning how to use the new keyboard. You get some error detection. Again, those error detection components coming from that cerebellum say, hey, you didn't execute that properly. This is how you make that correction in the future. Next is bilateral transfer. So it is also referred to as intermanual transfer, cross transfer, or cross education. And this is something that physiotherapists use very, very frequently, especially with stroke patients. And we're going to talk about that in the coming moments here. So we have symmetry versus asymmetry with bilateral transfer. So does a greater amount of bilateral transfer occur when a person learns a skill using one limb before learning it with the other limb? So asymmetric transfer, or is the amount of transfer similar when either limb is used first? So symmetrical transfer. And what I would say is that if we take the example of someone with a stroke, we talked about this, right? Like sometimes we force people to use their affected limb. We'll actually put their usable limb, we'll put it in like a sling so they can't use it, and they're forced to use that other arm. And so I think what you need to take into context here is, how do you learn how to use your other arm again, right? How do you learn how to use the arm that's affected by a stroke? Well, you need to figure out a pattern in which that works. So the reason why asymmetric transfer is preferred is because you need to be able to store the memory of how you use your other arm, your non-affected arm, in order to apply it to the affected arm. So the way that we do this in physio is we get people to actually do a movement with their good arm. Say, hey, do this movement like 20 times, right? Reteach your brain how to do this, right? Hey, brain, pay attention to how I lift my arm in this way a whole bunch of times. You know, really take that in, and then go back and force your other arm that's affected to do that motion. So you want to be able to use that asymmetric bilateral transfer in order to get people to continuously relearn those skills. So yes, we want to force you to use the bad arm, but we also want you to learn how to do it with your good arm first. So now, why does this happen? And so I kind of talked about this just very briefly, but the cognitive explanation states that the basis for positive transfer from a practice to a non-practice limb is the important cognitive information related to what to do to achieve the goal of the skill. So again, you need to process, you need to use your brain in order to figure out how to do it. You know, what am I trying to do here? I'm trying to lift my arm up. I'm trying to reach out and grab this glass. I need to process how I do that. Like, what muscles do I use? How does my arm move with my good arm to get there? And then I can come back with the unused arm, or the bad arm, quote unquote, and I can say, can I do that again? And that's how you start to process and use that cognitive component to improve that movement skill. So again, you store that stuff in memory, and then it's made available to you when you go to use the other limb. So this is kind of like an example of, again, people with amputations, people with strokes. We will get people to, again, he splints this one arm, so he can't use the quote-unquote good arm, and then we force him to use the bad arm later on after he's practiced that skill multiple times with this good arm. So again, that would be kind of that bilateral transfer, or what we call cross education, and that's a term that we use a bit more frequently in the physio world. So how do we measure it, right? And so what we typically do is we measure things like EMG activity, right? So does it show us that we're using that arm a little bit more effectively? Are we using the proper muscles to do it? And so when we click on this, it says EMG activity is transferred to other limbs. So left arm gets EMG activity when the right one is the only one that's moving. And that's what we call cross education. That's why when we get people to do rehab, even when people have like a shoulder surgery and they're in a splint, I'll say, hey, go work out your other arm, right? Go train your other arm, because we actually see some strength improvements in the arm that's in the sling, even when they're not using it, because your brain has this amazing ability to transfer over some of that learning and some of that strength gain that you get in the arm that's not affected, and then transfers it over to the arm that is affected. So whether that is a stroke or a surgery or whatever, it's important to go train that other arm, even though it is technically the quote-unquote good one. We can also use things like fMRI to establish neural basis for bilateral transfer. Do we see brain changes, even though we're only using that quote unquote good arm? Are we starting to see some changes that way? And then finally, the research evidence indicates that both cognitive and motor factors are involved in bilateral transfer. It seems pretty obvious, right? Like, obviously, you need some muscular changes, you need some EMG change to the muscles, but your brain is kind of like that central command center. It's the thing that you need to have change in order for the nerves to process that information, for your nervous system to be able to transfer over. So make sure that when you are thinking about transfer of skills, that you're taking into consideration that positive transfer is obviously what you're trying to do, that negative transfer isn't necessarily a terrible thing in the long term, but you want to make sure that all of that is being integrated into skill learning and how the brain and the muscles both are implicated in transfer, especially when we're talking about injuries like strokes or even shoulder surgeries, knee surgeries, anything like that. It's important to train the other side, even despite those things. So again, take those things all into consideration when it comes to skill transfer. That is the end of Unit 4. This encompasses Chapter 11 through 13. Make sure you guys keeping up on your quizzes and your chapter reviews. Don't forget to do that as well. And I will see you soon for Unit number 5.